Um, Hello for the ones that they join us so far. I'm just going to give everybody maybe another minute before we start. So just and okay. Apologize for this awkward silence, but I was trying to give everybody a little bit of time to join us. So we can be ready to start. So hello, and thank you for joining us for the ACSM Northwest Educational Webinar Series, supported by a grant from the American College of Sports Medicine. My name is Harry Papadopoulos. I am the past president of the chapter and the moderator of today's webinar. Before I introduce our speaker, I would like to mention a couple things. The ACSM Northwest annual meeting will take place on February 28th and 29th at Boise State University. It is not too late to register if you want to attend the conference. We have great speakers and presentations by undergraduate and graduate students from the Northwest region. I hope to see you there. If you want to post a question for our speaker, you can click on the question mark that's on the top of your screen and you can type your question. At the end of the presentation, I will ask a few of those questions to our presenter. So it is my privilege to introduce today's presenter, Dr. Catherine Schmitz. Dr. Schmitz is a professor of public health sciences at the Pennsylvania State University's College of Medicine. She is a clinical trialist who has led many exercise trials. She has also translated her work into clinical practice and has published over 240 peer-reviewed scientific papers and has had $25 million in funding for her research since 2001. She was the lead author of the first ACSM roundtable on exercise for cancer survivors, which published guidance for exercise testing and prescription for cancer survivors in July 2010. In June 2017, she became president-elect of the American College of Sports Medicine. She assumed her presidency in June 2018, and as of June 2019, she became ACSM's immediate past president. In March 2018, Dr. Schmitz chaired an international multidisciplinary ACSM roundtable on exercise and cancer prevention and control. The physicians, outpatient rehabilitation specialists, researchers, and exercise professionals in the room broadly agreed it is time for exercise oncology to go prime time. The question is, how? Dr. Schmitz's professional mission is to answer that question. Our title of today's presentation is Moving Through Cancer, Exercise is Medicine in Oncology. Dr. Schmitz.
Hey, well, whoever that is sounds much older than I am. I don't know. I guess I did some of that. Thank you very much for the kind introduction and for the invitation to speak to you all today about something that's very near and dear to my heart. I will point out to you that on my opening slide, I do have my Twitter handle, my Instagram handle, and the hashtag of exercise oncology that is broadly used on Twitter and Instagram. I believe that social media is going to be a very important vehicle through which we will translate the evidence base and shift the paradigm that currently exists of, when you think of a person, close your eyes and think of a person with cancer. Is that person in motion, or are they lying down with a blanket over them? that's, we need to shift that paradigm so that people start to think of cancer as being associated with being physically active. So this story begins with the first ACSM roundtable, which, I was a junior investigator at the time and was at the University of Pennsylvania and was honored by this esteemed panel to be invited to lead the writing of this piece, which was the first guidance that ACSM published on the topic of exercise for cancer survivors. Based on where the field was at that time, that guidance was really focused on safety. It was focused on whether or not it was okay for people with cancer to move at all. It was really evidence-informed and expert opinion as opposed to really, evidence-based because of the volume of and quality of the evidence at the time that we published this. It was very public health oriented and based on the timing, because the first Physical Activity Guidelines Advisory Committee in the U.S. published their findings in 2008. So we had our meeting in 2009 and published the paper in 2010. So we really had this kind of a reaction to the Physical Activity Guidelines Advisory Committee report, the first one back in 2008, which started with 2 words: to avoid inactivity, and we adopted those 2 words within the cancer survivor guidelines. And then we copied exactly what the physical activity guidelines for all Americans were: 150 minutes a week of aerobic activity, twice weekly resistance, and flexibility on most days, because really we were in a situation where we were responding to a lack of evidence, and the concept basically came down to, well, is there any evidence that people with cancer shouldn't do the same amount of exercise, as opposed to being able to say that by doing a given amount of exercise that, a given outcome will occur. So this was really early days in the field. So, and just to give you kind of a framework, this slide was put together by Joachim Wiskman from the National Center for Tumor Diseases in Heidelberg, Germany, for the second ACSM roundtable. And the first thing I want to point out to you is that in 1996, Christine Friedenreich and Carrie Cornier published a review of the state of the field in exercise oncology, and they were able to find 4 randomized controlled trials at that time. Fast forward to the first ACSM roundtable, which occurred in 2009, was published 2010, and we had 151 randomized controlled trials and 76 in physical activity and cancer, and there was a 281% increase in the number of randomized controlled trials between that and the second roundtable by 2018. So this is a field that has truly grown exponentially in the past several decades. And as a result of that, the American College of Sports Medicine saw fit to have a second roundtable. This one was different in a couple of really important ways. One was that we noticed that after the first roundtable, nothing really changed in the clinic. Nothing changed with regard to getting more cancer patients access to high-quality exercise. And so we wanted this to be multidisciplinary and to include all of the different clinical specialties that touch the patient as people are going through their treatment. We also realized that there was a very large international exercise oncology community, and that we really wanted to get the best and the brightest in the room, and so we included partners from around the world. You can see the partner organizations listed here: the American Cancer Society, National Cancer Institute, American Physical Therapy Association, and a number of other partner organizations from around the U.S. And then on the right side are listed the 5 international partners that worked with us to carry out this important meeting. So there were 3 papers that were released last fall as a result of the work that was done at the roundtable. 2 of them were published in MSSE, and they were really focused on, the first one was focused on exercise and cancer prevention and recurrence. The second one was focused on fit prescriptions, frequency, intensity, time, and type prescriptions for very specific outcomes during and after treatment. And then I led a third paper that was about exercise is medicine and oncology, how we get clinicians to be more involved in translating the evidence base that is presented in the first two papers into clinical practice and get more patients moving. These three papers form the basis of what I will talk to you about today in our webinar. But in addition to that, I want to make sure you know that they are freely available on the Moving Through Cancer website. The Moving Through Cancer website is very easily found. It's exercisesmedicine.org/movingthroughcancer. That'll be repeated on a slide later in my presentation. So the first of these papers was led by Alpa Patel from the American Cancer Society, and this was the one that was really about whether exercise has a preventive effect for cancer as an original diagnosis for cancer incidence, and whether exercise has value for prevention of recurrence and death after you've had a diagnosis of cancer. So the summary, and this is just so unfair because I'm trying to cover so much, but this incredible piece of work that was really a review of meta-analyses, review of systematic reviews, came to a number of extraordinary conclusions with regard to the level of evidence, strong, moderate, or limited, for physical activity and lower risk of developing incident cancer, as well as the growing body of evidence, really emerging body of evidence on sedentary time and higher risk of developing cancer, and then pre and post-diagnosis physical activity and risk of cancer-specific survival. So I really want to point out to you that the leftmost column, the one about physical activity and lower risk of incident cancer, is remarkable. If you think about the number of cancers that are listed here, we are able to conclude that there are 7 different sites for which there is strong epidemiologic observational evidence that being more physically active is associated with reduced risk of all of these cancers. And then there's moderate and limited evidence for a number of other sites as well. But the other column that I want to really focus on today is the rightmost column, in which we show that we have moderate level of evidence for the fact that if someone has had a prior diagnosis of breast, colon, or prostate cancer, that there is moderate level epidemiologic observational evidence that if they are more physically active, that we can promise them a reduced risk of cancer-specific death and a lower risk of cancer-specific lower risk of cancer-specific death, better likelihood of cancer-specific survival if they are more physically active. And one of the things that's not able to be summarized on a slide like this that's really important is to understand the magnitude of these effects. They can be up to 40, 50, even 60% reduction in risk depending on the cohort study that you're looking at. So we're not talking about small effects. Just as an example of one of the many studies that was used in the analysis that was led by Dr. Patel. These slides are directly from what were presented at the roundtable and shared with me by Dr. Steve Moore from the NCI. And this was an analysis that was done using the physical activity collaboration of the National Cancer Institute Cohort Consortium. For Canadians that are on the phone, I do apologize that the green on this slide seems to indicate that the United States has appropriated Canada. I know that we have not. My apologies. It's the way this slide was given to me, and Steve knows that this is a mistake as well. So anyway, this particular analysis included 8 U.S. cohorts and 4 European cohorts with 1.44 million participants and 187,000 incident cancers. So the point is an enormous cohort. And so what they were really looking at is leisure time physical activity, looking at moderate and or vigorous intensity activity. And the main results are shown here. And for those of you not familiar with the forest plot, the idea here is that there is one vertical line on this graph here and this table. And the vertical line shows you when there is no relationship between the exposure of physical activity and the outcome of the particular cancers that are listed in the rows. And if the dot or square is to the left of that vertical line, then there is a reduction of risk. If the dot is to the right of the vertical line, then there is an increased risk for being more physically active. So this is the main results. And one of the things that I want to make sure that I say that I think is important to point out is, for the most part, although there is a reduction of risk by being more physically active for most cancer sites, it is important to note two things. This slide is not adjusted for body mass index, which should then bring question to mind, wait, is this because of the effect of physical activity on body mass index? The other thing to point out is that there is one cancer for which there is an increase, a statistically significant increased risk of incident cancer as a result of being more physically active. And that's the lowest row on this slide, that for malignant melanoma. Most people on the call are probably going to say, well, yes, of course, that's because people are more outside more if they are more physically active. That could be. That could well be. We don't actually know, and it's an active area of investigation. So this is, I guess, my moment for the public health message of making sure that you do the slip, slap, slop of all of, the sun protection that you can if you are going to be physically active outside. So just pointing out that increased risk with melanoma. So the big question here is it obesity? And so I'll just cut to the chase because I have a number of other things to talk to you about, and say that there are a number of cancer sites for which there is still an association of reduced risk for these cancers after adjusting for BMI. And they include esophageal adenocarcinoma, lung cancer, kidney cancer, myeloid leukemia, myeloma, colon, head and neck, rectum, bladder, and breast. So to summarize what Dr. Patel and her colleagues found for prevention of recurrence of cancer, prevention of all-cause and cancer-specific mortality, really the top three lines say it best. We're actually able to give those who have had a diagnosis of breast, colon, and prostate cancer tremendous assurance that if they are more physically active, that is something within their control, which does have an association with reduced risk of cancer-specific and all-cause mortality before and after their diagnosis. This is all summarized in an infographic that was put together by the American College of Sports Medicine. These are the cancers for which we are able to conclude that there is a statistically significant effect of reducing risk of incidence of each of these cancers by being more physically active. But what about all of those other cancer health-related outcomes, the symptoms, treatment tolerance, adverse effects of treatment? This was summarized in a paper that was co-led by Dr. Kristen Campbell and Carrie Winter-Stone. And, I can't tell right now. It could be Carrie's on the call. And if I say something wrong, I hope she'll speak up. What we're really looking for in this analysis is how we can go about giving cancer patients who are going through treatment and have survived their treatment, specific information of the frequency, intensity, time, and type of exercise that they can do in order to affect change for a very specific cancer health-related outcome. So in order for us to do this, we had to have some kind of rubric to decide, yes, there's enough evidence, or no, there is not enough evidence. And so we used a decision tree that was adapted from the development of the Dutch Physical Activity Guidelines, given one of our panel members that helped us with this had been helpful in the Dutch Physical Activity Guideline development. So as you can see here, if we had fewer than 5 studies, we decided there was insufficient evidence. If there were 5 studies, but really not much effect, then we gave no fit prescription. It was only when we had at least 5 studies with at least 150 participants, an effect not close to zero, and hopefully no heterogeneity, but even if there was, if we saw there was some kind of emerging potential of benefit, we would provide a moderate level of evidence or a high level of confidence that we had an effect and provide a fit prescription. So these are the outcomes that were examined. So I just want to point out that basically the process for doing this paper was, in essence, a systematic review on each one of the outcomes you see before you right now. There was a group of remarkable investigators that came together, and we divvied up the work, but Carrie and Kristen really expertly led the team, along with the help of professional librarians who helped us with the literature reviews. And we are able to give strong evidence on all of those listed in the green box, moderate in the yellow box, and then the things that, if you are a master's or a doctoral student looking for a thesis, you can focus on all of the things to the right. Those are the ones that we feel that we need additional evidence on. So I'm not able to go through the evidence review for all of the outcomes that we reviewed. I'm going to go through 2 of them in order to give you an example so that you understand the process that we went through in reviewing the evidence in order to come to the conclusions that we came to. So the first outcome that I will do a review of, because it is the one with the largest amount of evidence of all of the ones that we reviewed, is cancer-related fatigue. The prevalence rate during chemotherapy is 90 to 100%, so this is a ubiquitous problem for people who are undergoing cancer treatment. There are over 200 randomized controlled trials that are currently available, and this is indeed the largest evidence base in the field of exercise oncology. It was reviewed in a systematic review and meta-analysis by George Kelly fairly recently. So the results are available for a variety of different cancer tumor types, treatment types, timing within treatment, as well as the different modes of exercise. And the conclusions from another review on this topic are that aerobic exercise has a positive effect on cancer-related fatigue. So does resistance training. But please note that the combination of the two appears to have a larger effect size. It is not statistically significantly larger, but it is a larger effect size. So if I'm telling my mother what I want her to do, or my loved one what I want her to do, I'm probably giving them a combined program because of what I'm seeing on this slide. Overall, the effect size is in the low to moderate size of 0.32. And one of the things that is particularly helpful for us to understand is Dr. Bouffart from the Netherlands has done a meta-analysis that has shown not only do we have these effects, but that patients with higher levels of fatigue seem to benefit the most from a program of physical activity. Another thing is that this is extraordinarily robust with regard to cancer type, presence of metastasis, treatment type, or treatment status, whether you're doing it during treatment or after treatment, whether it's delivered supervised or at home, whether it's group-based or not, type of exercise, duration, et cetera, et cetera. There is really robust evidence here. Finally, and what I'm showing you here is a summary of a paper that I believe to be one of the most important papers in the field of exercise oncology. This is by Karen Mustian and her group. And what she shows is what happens and what the weighted mean effect size is, that's WES, for 69 different papers that have looked at the effect of exercise on cancer-related fatigue. And she then compares that to what kind of effects we are able to see if we use a drug, if we prescribe something, a pharmaceutical intervention for cancer-related fatigue. And I want you to notice that the weighted mean effect size for pharmacologic interventions for cancer-related fatigue is smaller, and indeed not even statistically significant, than the effect for exercise. So you can go to the bank with the idea that exercise has a better effect than any drug on the market for cancer-related fatigue. It should be noted that psychological interventions also have a robust effect on cancer-related fatigue, but I will note that exercise plus psychological interventions, one row up from that, does not have a better effect. More is not necessarily better in interventions. So to sum up what we've found in the realm of looking at fatigue as an outcome, aerobic exercise and or resistance training exercise both positively affect fatigue. We have stable effects for all modifying factors. It's seen for general fatigue, overall fatigue. So the range of the fit prescriptions that were applied in the various studies for resistance training was anywhere from 2 to 3 times a week. Aerobic exercise was anywhere from 2 to 6 times a week. The intensities are shown there as well. I won't read the slide to you. You can see the amount of time that was prescribed as well, and then the type of exercise that was prescribed. This was the basis for our conclusions that we drew from the roundtable for cancer-related fatigue. So I'll do just one other one. and that is for lymphedema. And these outcomes are specific to breast cancer-related lymphedema. This is an area that is very dear to my heart. This is where a lot of my work is focused. There have been 5 trials that have been done in this area, and Ahmed was actually mine. That was my doctoral student, and then I've got 2 more in here. So I have contributed a great deal to this particular outcome. One of the studies that is a focus of our ability to draw these conclusions is the PAL trial. The PAL trial was a 1-year randomized controlled intervention with twice-weekly progressive strength training compared to a non-exercising control with a primary outcome to determine whether there were any changes in lymphedema outcomes, with really 2 separate trials funded by 1 grant. One trial was specifically for women who walked in the door with a diagnosis of lymphedema. The other trial was for women who walked in the door without lymphedema, but at risk for the development of lymphedema. And we powered these trials independently. One of the studies was published in the New England Journal of Medicine in August 2009. The other one was published in JAMA in 2010. And to summarize the findings from this particular set of studies, twice-weekly slowly progressive strength training was found to be safe for breast cancer survivors who have lymph node removal, including those with and at risk for lymphedema. The risk of lymphedema flare-ups was decreased by half, which brings to question the possibility of cost effectiveness, given flare-ups are a very time-consuming and costly medical event to deal with. Among women at risk for lymphedema, those who had 5 or more nodes removed had a reduced risk of increased arm swelling, which is a harbinger of onset or a diagnosis of lymphedema. This was reduced by 70%. So twice-weekly, slowly progressive strength training seems to be preventive or protective for lymphedema. We showed substantive strength improvements in body image and appendicular skeletal muscle mass, as well as preventing a reduction in physical function as compared to the control group in this trial. So that is one of the grants, 2 of the trials, and there were 5 total in this area. So I just want to point out to you that in some cases, as we were reviewing those 16 different cancer health-related outcomes, sometimes, like I showed for the fatigue, we were reviewing reviews. And in other situations, we only had 5 studies, like in lymphedema, in which case we were reviewing the trials. We were looking for the number of people who were examined in each of these trials. So that's just to give you an idea of the range of the ways that we were reviewing the data. To sum up for lymphedema, we did find a finding of safety for resistance training, and that is, in fact, what the recommendation is. It is not a recommendation for a fit prescription for a benefit for lymphedema. It is a fit prescription that says you can do this and know that you will be safe. All trials started with the women doing supervised exercise, and all started with the concept of starting low and progressing slow. So that is advice that we give in our recommendations in the MSSE paper. The preliminary data that is available for lower limb lymphedema does not support assuming that these results translate to other settings, to either for head and neck cancer, for not upper extremity, but for head or neck lymphedema, or for lower extremity lymphedema. We have no evidence available for aerobic training, but there are so many studies that have included women who have breast cancer-related lymphedema, that have included aerobic exercise, that have reported no adverse events, that there is a presumption of safety based on lack of reports of adverse events, even though there's been no particular study, nor do I doubt anybody is ever going to fund a study for us to examine whether doing more aerobic exercise is good for lymphedema. So just to summarize, this is hot off the press. This is a brand new infographic that has been developed in order to express the results of both the first and second paper from the roundtable. And this has been through 10 rounds of revision, and we are currently gathering data from patients in order to see if there are any further revisions. But the idea is moving from the top to the bottom. We have started a new initiative at ACSM called Moving Through Cancer that lives underneath the umbrella of the Exercise is Medicine initiative. And it is, in essence, Exercise is Medicine in oncology. And so if we start from the top where it says moving to cancer, the first thing to tell people is avoid inactivity, which is where we really start to talk to that paradigm shift and the need for us to have that paradigm shift so people think of movement when they think of people with cancer. And then for overall health and to meet the current exercise guidelines and for reduction of risk of recurrence of cancer, then we give the overall guidelines that are available within paper 1 that was led by Alpha Patel. Sorry, I still think of them as papers 1, 2, 3, and nobody outside of the roundtable group knows what that means, and I sometimes forget that. My apologies. So the paper by Dr. Patel is really the for overall health section. And then the paper by Campbell, Winterstone et al. Is where we get into the section that's white here for people during and following cancer. And you can see that there are 8 different cancer health-related outcomes for which we are able to give a fit prescription, and the fit prescription is listed below. So an overview of what we find from all of what the roundtable concludes, start with the words avoid inactivity. We provide the general public health guidelines for primary and secondary prevention, which is 150 minutes a week. For specific outcomes where we don't have a fit prescription, the advice is to default to the general public health guidelines, 150 minutes a week. And then there are 8 cancer health-related outcomes with specific evidence to say that we can do less. Very specifically, aerobic exercise 3 times a week, up to 30 minutes, and resistance training, 2 sets, 8 to 12 reps, 2 times weekly, with no comment on flexibility activities, because indeed, there's not an evidence base for us to be able to make that comment. One of the things that I'll comment on and perhaps preclude some of the questions that might come later is, whoa, this is a little confusing. Why don't we just tell everybody 150 minutes a week? And the answer is fairly straightforward, and that is, if you are someone who is in cycle 4 of going through CAPOX, which is a chemotherapy regimen for colon cancer, you probably are, fighting your way to get off the couch and get moving at all. So if we can give them assurance that doing twice weekly strength training, and that's it, and that's all they need to do, is actually going to help their fatigue and some of their other symptoms, that's really worth doing. That's worth being specific. Another way of thinking of this greater specificity in our ability to prescribe exercise during and after cancer treatment is to think of nutrition guidelines. The general nutrition guidelines are out there. We should all be eating more protein, less fat, this many, like we can argue about what they might be or what they should be if you're somebody who believes in keto or not. That's not what this webinar is about. Maybe you guys can get a different webinar about that. But meanwhile, there's then going to be very specific guidelines for people who have kidney disease. There's going to be, to eat less protein. There's going to be specific guidelines for people with hypertension to reduce their sodium. So there's going to be, specific guidelines for cancer. There's going to be, very specific guidelines for different kinds of disease states or health promotion that is specific to a particular population. So that's why the great news is that we are able to be more complicated now. The great news is that exercise oncology is able to prescribe exercise like a drug with that much specificity for specific outcomes for people living with and beyond cancer. The third paper from the roundtable is the one that I led. This was published in CA, a journal for clinicians. It wasn't in MSSE on purpose. It was in CA because we wanted to get in front of cancer clinicians with this information, and the current state that we find ourselves in that we're trying to fix with this new paper is that less than 25% of cancer patients are inadequately or are adequately active. And the reasons for this are multifactorial, but one of the things that contributes is a lack of referral from clinicians. One paper tells us that 9% of nurses refer patients to exercise. Another says that we refer somewhere between 19 and 23%, so about 20% of physicians refer their patients to exercise. So how do we fix that? How do we make that happen? So, well, the first thing to ask is, well, why aren't they? Why wouldn't they be doing it? One is simply a lack of awareness. They may not understand the potential value. Another is uncertainty regarding the safety or suitability for a given patient. Another is lack of awareness regarding the available programs in their area. So we need to educate them and help with skills development for making referrals. There may also be a belief that referrals to exercise programming is not within their scope of practice, because understand that clinicians are awfully busy as they are caring for their patients. So please know that anything that I am saying about oncology clinicians and anything they're not doing is not intended to say that they are at fault. It is intended to reflect the honest truth about what's happening in clinical oncology and to start to reflect honestly and openly on how to fix it. The recommendation is to apply the exercise as medicine approach, the physical activity as a vital sign approach, to assess, advise, and refer patients to exercise. This is very similar to the approach that is already presently used for psychosocial distress screening in the setting of oncology. So probably folks on this call are not particularly familiar with this, but the American College of Surgeons Commission on Cancer accredits most cancer centers across the country, and they have a recommendation or a requirement, not a recommendation, a requirement that each cancer center have a method in place to assess psychosocial distress in their patients because of a finding that the amount of distress that a patient is under is reflective of how well they do with getting through their treatment and survival. So addressing distress is an important thing for us to do. And so they had to figure out a way to ask people, hey, are you distressed? Are you okay? Is it because you're emotionally distressed, financially distressed? What are the issues that are causing you distress? And then once they find something, then they are obligated to make a referral to somewhere else. And this is a really important sort of model for us, because one of the things that clinicians might be concerned about is, hey, I'm not an exercise physiologist. I can't prescribe exercise. Well, the answer to that is no, and you're also not a psychologist, and we're not asking you to prescribe psychotropic drugs or recommend therapy. What we're asking you to do is ask about distress and then refer appropriately to people who can take it from there. So one of the catch-22s in this situation is that clinicians are asked to clear patients for exercise for many programs. This is true not just in the setting of oncology. And so we ask clinicians to clear for that program, but are they really qualified to do so? They may or may not be. If not, who is? And who in the system can do this work? We really don't have a validated triage schema in oncology or, frankly, any other setting. And this is a place where we need to do further research in order to move the field forward. The other issue is refer them to where? So we've tried to start to answer this question with the development of a registry of exercise programs for people living with and beyond cancer. There's the website for Moving Through Cancer where you can find those 3 papers that I noted before. And if you have a program that you're running, or you know of a program that is being run for patients, I hope you'll go look, see if they're in the registry, and if they're not, please sign up to be a part of the registry so that people can find you. This is what the registry homepage looks like, and you can see the exercise programs registry big green button right on the homepage. There are also prescription pads that have been developed that are there for the purpose of making it easier for clinicians to be able to make these kinds of referrals. There are, however, we recognize a huge number of other challenges. The transitions, if the doctor decides that the person should be referred to physical therapy, okay, great. The physical therapist finishes with them. Does the physical therapist know about the community programs? Does the physical therapist know to refer the person to the community? If the people in the community are doing a program and the person has an injury, do they know who to send the person to at PT? There are behavioral issues. There are workforce development issues right now. If you go, there is one program in the country that has a very specific exercise oncology focus. It's in central Pennsylvania, of all places, St. Francis University. There's a master's program specifically about exercise oncology, but I am unaware of any university anywhere else in the country that has a major focus on exercise oncology that includes major, sort of coursework and whatnot. We're trying to fix that. There is a new textbook that has just been approved at ACSM that should be available in another year or 2. There are policy issues with the triage methods. We certainly need to figure out how to pay for all of this and have trainers be paid to do this important work. The Moving Through Cancer Initiative has a steering committee, as kind of a task force, if you will, that has developed a strategic plan for all of this work that is very much in keeping with American College of Sports Medicine new management operating system called Continuous Improvement System. And so there are all these phases, and there's a lot of work that needs to happen. But if I were to sort of bucket it into three basic categories, we have a major task to increase awareness on the part of patients, on the part of the general public, on the part of clinicians about the benefits and value of people being more physically active during and after their cancer treatment. We have behavioral programming and practice issues. We need to develop more programs. We have an issue of needing to increase the workforce as well. And then there is, of course, the policy funding and sustainability issues that, in our view, are more phase 3 to phase 5 issues, because we really need those things to sustain any programming that we start. So I'm going to finish off with what's possible and a few examples of, we've been talking in the abstract. So now let's talk about actual human beings who are living and breathing these stories. So the first story is my friend Bill Jolly, who goes by Jolly. Yes, he is Jolly. And this is what he calls exercise oncology in action. So first, what you see is a picture of Jolly in spring 2011 at 210 pounds. It had been 15 years since he left the Marine Corps. He was 40 years old at this time, and a friend of his invited him to train for a sprint try. And a month later, he was just totally flat out after 5 laps in the pool, and asked the question, I know I'm out of shape, but shouldn't I be this tired? He developed chest congestion. They couldn't figure out what was going on. They thought he had asthma. He did a swim, run, brick, and a mile in. He was wheezing so loud it sounded like he swallowed a whistle. He got a chest scan in the fall. It was reviewed in October, and the radiologist was able to diagnose that he had stage 3 lymphoma. A biopsy confirmed that diagnosis, and in January, the following January, he started his first 6 cycles of chemotherapy. The same month, he started training with the Leukemia Lymphoma Society for his first race. 5 months after chemo, he completed the Marine Corps Marathon. He's got kind of a proud smile on that face in the top left, doesn't he? In 2013, he's shown his guns at the Outer Bank Olympic Tri. In the bottom left, you can see that he did another Olympic Tri in 2014. He did a Bull City Half in 2018. 2016, he relapsed and started doing oral targeted therapy. The following January, he was really feeling fatigue. Growing fatigue was really just getting worse. And he says, I felt myself going to a dark place, and I didn't like it. I didn't want to work, didn't want to talk to my wife or kids. After 4 days of increasing depression by day, I told my wife at 10:30 at night I had to go for a run. 1 mile into the run, my fatigue and depression just vanished. I discovered I could keep the fatigue and depression at bay as long as I exercised every other day. And you can see, very proud moment, that October he finished the sprint distance marathon, Ironman, in North Carolina. He does have ongoing symptoms, and he controls them with stretching and with valcyclovir. So this is so everybody should feel very, very lazy right now. This is somebody with stage 3 recurrent lymphoma. And what he says, and I love this at the bottom, he says, sometimes with a 5-month-old foster child that he's now adopted, by the way, and a busy career, he almost always gets his Saturday, Sunday workouts in, but only 2 to 3 workouts during the week. So anytime you're feeling like, I don't feel like it today, just think about Jolly, okay? So his takeaways, and he allows me to tell his story as long as I show this slide. You want to teach your patients to listen to their body. They will know when something's off before a lab test. If something feels off, don't ignore it. Be quick to refer patients to allied health professionals such as exercise, nutrition, psychology. Medicine and surgery are not the only tools. Exercise can reduce or eliminate medication symptoms and reduce recurrence for some cancers. And here's the big part. Exercise gives patients control of their lives back. Another case study, just to finish up. This was a patient of ours at Penn State. She was 61 when we met her. She had metastatic breast cancer. She was metastatic at diagnosis in 2016. She had compression fractures. She had had surgery to deal with spinal cord compression. She was also dealing with a number of other chronic conditions. When she was enrolled, she walked in and she kind of looked like, think about a question mark, the shape of a question mark. She was kind of bent over like that. She was really sort of ambulated with a walker. She could walk a little bit and then had to take breaks and sit down due to weakness. She'd had the spinal surgery and had been told she would be bedridden most of her life. We were doing a tablet-based supportive care intervention that asked daily symptom questions and offered daily interventions, including physical activity, with a weekly navigator call. This is kind of a navigation through the whole thing. So we had this navigator call that we would do once a week at the bottom left. And if you start at the top, they would open up Nurse Amy, and the nurse would say hello, and it would actually talk to them and say, oh, it would say something silly every day like, whew, it's dark in here. Thank you for opening it. And, and then would ask a symptom question, and then the expression of the nurse would change according to what they say in the symptom question. So that if they slid the slider and they said their fatigue was terrible, then the nurse would look upset and say, oh, I'm so sorry you're dealing with this. If the person would say, my fatigue is very low, then they would clap their hands or laugh, and say this is great. And then they would offer an intervention. These are not just interventions we drew out of a hat. These are guideline concordant, evidence-based interventions specifically for the 4 different symptoms that we were dealing with in Nurse Amy. We also gave them a pedometer and a resistance band, because walking and resistance exercise was part of this. We also then had a dashboard that would know when people were having changes in symptoms, so we could see if their symptoms were changing in a bad trajectory. And as a result, we then would be in touch with physicians through the electronic medical record, so that they would have the option and the choice to say, oops, things are really getting worse for this person. They need to come in and have some other intervention. At the end of the study, Norma was averaging 10,000 steps a day. She was able to ambulate on her own with no assistance, but she came in swinging her cane like Charlie Chaplin to show us, that she didn't really need it. She carried it with her for long distances in case she got weak. When she met with the patient navigator, she strutted in that cane. Oh my God, that was such a great moment for all of us. So a quote from her from a qualitative interview: when I came over here, I was on the walker, but now I'm using the cane because I've been doing the exercises and my bones have been getting a lot stronger. I love Nurse Amy. It helped me a lot. When I do the exercise, it helps with the pain in my legs. I suffer a lot from pain. And the list goes on. Those of you that know her, Sydney Hooper is a pancreatic cancer survivor and Ironman competitor. Susan Helmrich is a 3-time survivor, DAS daughter, lung cancer and pancreatic cancer survivor and master swimmer. Gabriella Grunewald, who passed away this past summer, adenoid cystic carcinoma, diagnosed 2011. While she was a cancer patient, she was a sponsored ranked USATF runner, placed 4th, almost made it into the London Olympics while she had cancer, and won the national championship for the 3,000 meter in 2014. She had a saying over her couch: there are 2 ways to live your life. First is if nothing is a miracle. The other is as if everything is a miracle. So we know which one Gabe chose. She's the one behind the Brave Like Gabe charity. Mike Levine, stage 4 pancreatic cancer patient and Ironman competitor. He was near death's door when one of his former competitors came to him and said, come on, let's go for a bike ride. And he actually went back and did more competing as someone living with stage 4 pancreatic cancer. So he has passed away just recently. Keegan Randall was the last one I think I'll talk to you about. She is an Olympian. If you're not familiar with her, she is one of 2 women in the United States that has a gold medal for cross-country skiing. And she was already a phenom because she was a young mom when she was winning that gold medal. And 3 months after the Pyeongchang Olympics, she was diagnosed with an aggressive breast cancer. And she's an exceptional woman, but we want her to be exceptional in a new way. And that is, she had to go looking for clinicians who would allow her to continue to train. while she was going through treatment. And we want that to be the exception as well. It is time for these examples to stop being the exception. It's time for a paradigm shift, because exercise truly, truly is medicine for people living with and beyond cancer. So general conclusion for you is that exercise may not make the cancer go away. We're not stupid enough to believe that people are just miracle cures are going to happen because they take a walk, but it will put the patient back in control. So empowerment turns out to be something extraordinarily important to patients, and maybe really the key to how exercise has its benefits. It will help to manage symptoms while people are going through treatment, and it will slow the trajectory for loss of function and lean mass. Thank you very much for your attention.
Dr. Schmitz, thank you so much. I want to remind everyone that if you wanted to pose a question, please click on the question mark on the top of your screen, and you can type your question, and I can ask that question to Dr. Schmitz. We have one question, kind of maybe about how the information that you presented or can go to the can be translated to physicians, and how what steps we can do in order for us to make this one as more of awareness and a call on action.
Right. So excellent question, and I think that there are certainly some research efforts afoot to try to answer that question, but I think that all of them start with having a conversation with local physicians to understand what it is that they know, and to understand what their thoughts are. So if you are, moved to do something about this, that's the place to start, is to start with clinicians in your area, and not to go in saying you should be doing this, but to go in saying, are you aware of this? What do you think of this? Can I help you with this? To go in with a very open mind. Understand. I just want to say one more thing here. I alluded to this before, but understand that we have a tsunami right now of a mismatch of more cancer patients as our population ages, but not more oncologists. In fact, there might be fewer oncologists. And so the amount of time that oncologists have per patient is going down. So we're asking them to do something new and add to what they're already doing, even when they're already stressed about how they're going to fit in all of what they are supposed to be doing. So tread carefully with them.
Do we have any questions from the audience? Anything that someone would like to post? I'll give everybody maybe a minute. Maybe they can type something.
Okay.
In the meantime, some of the evidence or the information that we presented is that for studies that you did on strength training, is there a reason why you navigated towards strength training rather than aerobic exercise?
Yeah, I actually, this was a little backwards. Oh, Susan, hi. So sorry, I just unseared my screen to see who's on, and I see Susan's on. Hi, Susan. Yeah, I actually was not originally doing research in the area of exercise and cancer. I was doing research in the area of exercise and prevention of obesity. And I have, my first R01, my very first research was about the benefits of resistance training for potentially preventing the midlife gains of body weight that we commonly experience. And so I already had kind of experience in pilot work and whatnot in the area of resistance training. And so when I was invited to apply for a grant to the Susan Komen Foundation, I thought, well, I already, I have a track record in resistance training. Let's try this. As it happens, I started doing that work just at the time when some remarkable folks at the University of British Columbia had started to say that the myth that women shouldn't be using their upper bodies was just that. But at the time, the clinical advice was not to use their upper bodies, not to do anything, not to swim, not to lift anything heavier than 5 pounds. And so there was a controversy to be answered, and resistance training was the right place to go. So I came into it just at the right moment.
Okay. I have a question that it's asking, do you think research on the benefits of research is something that we will see in the future? And if yes, what are the obstacles that need to be overcome in order to do this?
All right, I missed say it again. Sorry.
Again, do you think research on the benefits of flexibility is something that we will see in the future? And what are some obstacles that might be?
Yeah, so there is some so there is Pilates, yoga. There are some there are some studies, but nothing rose to the level of 5 studies, right? We had to have 5 studies to include something in that paper too. Yes, I think that there will be. And I think that that is an open area of investigation. And I think that, one of the things that I would invite anybody thinking about going that direction to think about is, really think carefully about the types of outcomes that should be targeted in particular for cancer patients, and doing flexibility, and what outcomes do we think are of greatest importance? I think it will come.
Thank you. I would like to thank you. I would like to thank everyone for joining us today for this webinar. I want to remind everyone that we will make the webinar available. We were recording it. Thank you, Dr. Schmitz, for agreeing on that one. So then you can share with others that you may want to learn about this information presented. So thank you again for doing this wonderful presentation. Thank you, everyone, for joining us. Hope you have a wonderful day. Goodbye.
Bye-bye.